Hello, everyone. Welcome to another Rush Generations Health Education Lecture. Rush Generations and our staff is delighted to be your source of information, resources, and health promotion programs that help maximize your well-being and good health as you age. Today is Wednesday, June 26, 2024. My name is Patrick Stanley. I'm the program manager for community integration for the Rush Generations team, and I'll be your moderator for today's lecture, our Men's Health Roundtable. Before I present to you the wonderful panel joining us today, I'd like to be the first to thank Hannah for helping us with the production of this lecture to add to the discussion throughout the lecture. We will make sure that your comments and questions make it to the presenters. And for those of you listening to the discussion through phone, you will have an opportunity at the end of the lecture to unmute your audio so that you can ask your questions. We'd like to remind you that all information offered here is for general informational purposes only, and to always seek additional professional advice for situations that are specific to you and your needs. So, for our panelists today, we are introducing them alphabetically, and then I'll also let you know what order they're going to be presenting in, and then we will have a discussion all together. So first off, Dr. Fitzgerald received his medical degree from Rush Medical College and completed his residency in physical medicine and rehabilitation at Rush University Medical Center. Following completion of residency, he started as an attending physician as part of Rush University Medical Group, caring for a wide range of patient conditions, including post-stroke, spinal cord injuries, Parkinson's disease, musculoskeletal, and other musculoskeletal problems. Over time, he has grown his practice to include a comprehensive cardiac disease prevention program with cardiologist Dr. Danny Luger, seeking to provide primary prevention through a combination of lifestyle and medical interventions. Max also serves as the medical director for rehabilitation services and associate chief medical officer at Rush Oak Park Hospital. Dr. Levine is a graduate of the University of Colorado School of Medicine, and then completed 2 years of general surgical residency at the Tufts New England Medical Center in Boston, followed by a year in Paris at the American Hospital, where he was chief resident of medicine and surgery. He completed his urology training at the Harvard program in urology at the Brigham and Women's Medical Center in Boston. In 1987, he began as a assistant professor of urology in the Department of Surgery at the University of Chicago Medical Center. In 1992, he moved to Rush University Medical Center, where he remains as a professor of urology and is in active clinical practice with UroPartners Solaris Health. He established a fellowship in andrology and male genital reconstruction in 2017 at Rush. His focus and practice in clinical research is in the field of men's health, including erectile dysfunction, Peyronie's disease, urethral stricture, chronic scrotal content pain, hypogonadism, and male infertility. Thank you, Dr. Levine. You'll have to correct me if I got any of those wrong. And then Dr. Damian McKnight is a lifelong optimist, father of Zachary Eagle, writer, jazz head, and self-proclaimed and prescribed musicologist. He is a clinical instructor of family medicine and is a physician at Rush University Medical Center, preceptor in the Family Medicine Leadership Program, and past co-chair of the Diversity, Equity, and Inclusion Committee at Rush Oak Park Hospital. He is also a staff physician at Rush Anchor Medical Group in Oak Park, Illinois. Writing and music are his medicine from medicine. So when once asked if he had to give up either writing and music or give up solid food, rumor is that he hesitated. So without any further hesitation, I'll pass the mic off to Dr. Damian McKnight, who will be our first presenter for today.
Thank you, Patrick. Thank you so much. Thank you, Hannah. And, just kudos to this program. It has really been wonderful for my patients, and I've gotten fantastic feedback. And thank you to all of you who are joining now or in the future. I feel like this will be a wonderful time capsule. I'll show my son, who's turning 15 today. And I'll share a little personal note. When he was 10, I thought, I want to give him something for the future. This happened to be 5 years ago around COVID, and we all know what we were dealing with then. So I wrote him a letter that I'd asked him to open in 5 years. And since then, he's been getting a letter every year. And in that letter is an actual paper prescription from my practice, and on it is one word. Well, that word for him to take into the year, whether it's peace, health, safety. So this year he gets to open his letter written 5 years ago. So we're both excited about that. So this slide, I'll describe it. It sums up my approach to medicine. It is a slide of a sink that is overflowing with water, and there are two men fiercely and furiously mopping up the floor. Now, the sink is still flowing. Now, whether it's a broken sink or somebody just simply has decided or forgotten to turn the faucet off, I feel like this sums up how we sometimes approach medicine. So my philosophy is to turn the faucet off. And what I mean by that is, let's take a look at what is causing some of these problems. When you think about it, barring family history or accidents, most of our choices around diet, exercise, sex, drugs, alcohol, all funnel down to stress. So let's try to address the stress. Let's try to remove the barriers. Okay, so what is it that is preventing people from making healthier choices? Speaking of water, I prefer to give patients a fishing pole. Now, there are times whenever I need to give them a bucket or a bottle of fish. That's fine. We do that on the regular. But time and time again, I work with patients on lifestyle changes. How can we prevent problems before they start? How can we help lower the risk of problems or the severity of problems? And how can we get people feeling better? Because that's really what it comes down to. I want to give people the fishing pole, and it's up to them. They want to take it out of the box and open the instructions. So I like to be a guide. Now, a little bit of my background. I want to give credit where credit is due. I did get to slide from my mentor, a doctor by the name of Dean Ornish, who is a internal medicine doctor who's done a lot of work with reversing heart disease. I worked with him about 20 years ago in California. I did my residency at University of California, San Francisco. And he has proven with documented peer-reviewed studies, we can reverse heart disease and early prostate cancer with lifestyle changes. Low-fat diet, exercise, stress management, group support. These are the four pillars of his approach. And time again, study after study, he's proven that this works if people commit to it. Now, it is not easy, but it is, I believe, and I think a lot of people would agree, it is better than ending up with angioplasty or bypass or other things. So he's taken this on to early Alzheimer's and a mild cognitive impairment, which I'll talk about in a moment. But this has been the foundation of my approach to medicine. How can we prevent problems? I want to give people the tools. I want to give them, a fishing pole and a wrench to fix that broken sink. And what I do is I work with, again, removing the barriers. Try to make sure we're drinking plenty of water, getting rest, having quiet time, mindfulness. I take time to work with patients on belly breathing, breathing from the diaphragm. I know you're a music fan, Dr. Fitzgerald, so you remember the girl band ABBA. So I've taken that and made a little acronym called Always Be Belly Breathing Always. Because what this does is it is regular maintenance on our stress so that we can be more calm, more clear, and more focused. Why? To make healthier choices, to be more available to the world in front of us instead of thinking of what's happened in the past or the future. And so I'll just kind of briefly demonstrate and explain. So belly breathing is not just deep breaths. It is the belly coming out first, which expands the lungs. The belly comes out, lungs drop, we get 30% more oxygen. And the vagus nerve runs right through the diaphragm. So that helps to reset our parasympathetic, our sympathetic and our parasympathetic. So we're more in balance. Vagus nerve slows things down, lowers our heart rate, lowers our blood pressure, and allows us to be more calm, clear, and focused. So belly out first, force the air in the lower belly, chest rises last, pause for about 5 seconds, otherwise you get lightheaded, and doing this throughout the day. And lastly, being aware of the worry train. That voice that keeps telling us everything's going to go wrong. I'm not this, why not that? I do this visualization with patients before surgery because if they think of all the things that are going to go wrong before a procedure, they're going to get to the appointment and their blood pressure is going to be high and they're going to be so worried they're not going to have this procedure. So I visualize with patients from point A to point Z the night before, you get plenty of sleep, everything's set up, you get up on time, no traffic, you get to the hospital, everything's in check. The surgeons, the nurses are all in top form, you recover smoothly without pain. This allows people to simply take a nice deep belly breath and be more present and help with the healing and keep the sympathetic nervous system from taking over that fight or flight. Feeling like we're being chased by a tiger. There's no tiger in the room. So that's a little bit of my philosophy, and we can talk some more, but I'm happy to take any questions. And I really appreciate being asked to be part of this wonderful roundtable today.
All right. Thank you so much, Dr. McKnight. Next up is, I believe, Dr. Fitzgerald in cardiology. Go ahead.
Thank you so much. And thank you, Damien, for that awesome kind of segue for me. I'm going to have to try and figure out a way to name more of my recommendations after 70s rock and roll band. So that's on my to-do list. So thank you for that. I have some good work ahead of me.
Well, I got to say, Dr. Fitzgerald, I was supposed to follow you, and I wasn't happy about that. So there you go. The challenge is on.
Well, I just want to say, yeah, so this is actually a good segue going in from stress management, lifestyle intervention to kind of exercise and the role of exercise in health. And exercise definitely plays a role in stress prevention. And so I really, like I said, happy to be part of this, and it's a great segue for me. So, a lot of my practice revolves around movement and mechanics, and I think, as all adults, all children and adults, really, physical activity is becoming harder and harder to find as we've shifted to a more sedentary lifestyle, work environment, et cetera. And so, I think I'm not going to read all the information on the site. I'm happy to share the material so it'll be available to anyone that's interested. But the main thing I really talk a lot about with my patients and want to emphasize is that we get caught up in the notion of exercise. And when we use the word exercise, it has this sort of immediate guttural reaction that it has to be going to a gym, running, working up a sweat. But in reality, exercise is any planned physical activity that's structured and has a goal of maintaining physical fitness. So, there are a lot of things that qualify as exercise that we may not give ourselves credit for. And so, I wanted to highlight that physical activity, those are really the daily activities that are carrying a laundry basket, gardening, sweeping, doing things that we may not consider as dedicated exercise, but have tremendous health benefits if we do them regularly and kind of factor them in. And so I just, really want to emphasize that general physical activity is a protective factor against heart disease, stroke, diabetes, and even some cancers. So the more active we are, the better our overall health is, which is obviously you don't need a doctor to tell you that. But I think sometimes it's important for us to reframe how we envision physical activity, exercise, and its impact on our lives. And so one of the big highlights that, really important, and I'm sure people have heard this, this number cited before, is that 150 minutes of physical activity per week is kind of what the CDC recommends. And that is true. But what does that actually mean for you? And so I like including this slide. So this is the last time the CDC sent out guidelines. They're actually working on updating this, but this is from 2018. And this is like the physical activity guidelines, sorry, for Americans. And the point that I'd like to just emphasize here is that really for the vast majority of adults, whether you're 18 or 78, that really it's 150 minutes of moderate physical activity per week, or 75 minutes of vigorous activity. There should also be 2 episodes of resistance training per week. And then in older adults, 65 classified as 65 or older per the CDC, balanced training should be incorporated. Really, though, this is the line that I care most about. Sit less, move more, all activity counts. And that's the piece that I really want you to take away, is that there is no one right way to do physical activity. It's got to be very much what works for you, what's sustainable, what's repeatable. But that's, I think, the most important aspect of this is that there's physical activity, however you can do it and continue to do it is honestly going to carry the most weight, rather than, oh, I can only do it if I'm in the gym, whatever. So I just really want people to take that away. No reason to go through this, but just all the benefits that are associated with regular physical activity. So lots of good. And I think people often ask me, like, well, how do you know if something's moderate activity? How do you know if it's intense? And so there's this concept of metabolic equivalence, which is really less important. That's, METs there, but that's less important for people to know. The general rule of thumb is a light intensity activity is something where you'd be able to converse easily during that activity, maybe even sing. Moderate intensity is you can talk but not sing while performing the activity. So that'd be like a brisk walk, slow biking, some dances, although dance can be vigorous depending on the way in which you dance, and then home chores. And then vigorous activity is like you can't speak easily during the activity and are somewhat out of breath, usually can speak in sentences no more than 5 words at a time. So that's a good sort of barometer for what level of activity you're doing. When we talk about the recommendations for activity, it's the most important piece is that it's something that works for you, and everything is better than nothing. So anytime you're able to do some activity, that's better than doing no activity. Generally, if you haven't been active, a graduated approach to activity is really preferable to just trying to do all-in boot camp, go for gold from the outset. So kind of gently easing into activity, also that incremental change just from lifestyle modification has shown to be way more sustainable than trying to do a high intensity activity for a short burst of time. So kind of building up over time is really, really important. And I think for some people, they want to know, like, what should my heart rate be, right? I have a smartwatch, or the machine I use at the facility has a heart rate monitor, or can check your pulse. And so really, it's important to know kind of what target heart rates are. And I'll show you the next slide in a minute, but the maximum heart rate is 220 minus your age. And so your target heart rate for good, moderate to vigorous activity should be somewhere in that 50 to 80% of that range. So just as an example, if you are 70 years old, your target heart rate really should be somewhere between 175 and 125. So, can it go higher than that? Absolutely. But your target heart rate for maximal cardiovascular benefit and aerobic training should be somewhere in the neighborhood of like 75 to 125. And so again, this topic is like 4 to 6 hours of content, but these are really the big takeaways that I want people to leave with. Is just physical activity in and of itself is so important as we age, because as we age, sarcopenia takes place, we lose muscle mass, our bone health, it becomes a bigger factor and of greater concern. So the concept of fighting fragility is really, really heavily tied to your physical activity. And so finding ways to remain active, and again, just to emphasize, that doesn't have to be triathlon training. It can be chair-based yoga. It can be cooking dinner and chopping the vegetables. It could be anything that is engaging your muscles for a dedicated movement is really going to count. And it's also very important that resistance training factors into that activity. And it doesn't need to be heavy weights or, the Arnold Schwarzenegger type bodybuilding. It can really be something as simple as using an empty milk carton and filling it with water and lifting that in different movements, or getting some resistance bands. So there's all different ways to engage in that. And there are a lot of people who are happy to help you make a personalized program that will work for you. But that I can't emphasize enough. Something is better than nothing, and start slow and build up. And if you have questions, there's lots of us out here who will help guide you and give you tips and tricks. So with that, I just want to say thank you so much. And I'm thrilled to be here, and looking forward to the discussion later.
All right. Thank you so much, Dr. Fitzgerald. Without further ado, Dr. Lawrence Levine, pardon me. Please take it away.
Well, thank you very much. Well, I've already learned something today, which is always a good way to have your day, learn something and put it to work. So I was asked, I'm a urologist, and I've been here at Rush now for, I think it's going on 32 years. And I've seen evolution not only with Rush, but I've also seen it within my own field, which is a good thing. My specialty has evolved over the last 30 years to be what's called andrology. And andrology is really the study of men, or the study of men's health. And so I'm going to focus on some of the urological aspects of men's health. You've heard a bit about how important the ticker, the heart is, and how we can help preserve and maintain better heart health, which certainly can make a lot of the things that I'm talking about here can also work better. So in the area of men's health, what oftentimes comes to mind first is erectile dysfunction. Many years ago, we used to think of ED as being primarily a psychological problem, but I think we've come to learn over the years that ED is almost always primarily an organic problem, some physical issue. And what I like to refer to, the most common things that cause ED are the erection busters. So high blood pressure, elevated cholesterol, smoking, and diabetes. Any one of these alone, or certainly more together, can accelerate vascular aging. And of course, the erection is a vascular event. We need blood flow to fill the tank, so to speak, down there, and have the blood be properly trapped. And so those medical conditions will certainly put the foot on the accelerator of vascular aging, even beyond what will happen naturally with aging without any of those issues. ED is not uncommon. In fact, studies have been shown way back from the late 1990s that about 50% of men over the age of 40 will have some degree of erectile dysfunction. Certainly, as we age, we're more likely to have, more men are likely to have ED, and we're more likely to have more advanced erectile dysfunction. So, we can think of it in terms of, geez, I'm having a little trouble maintaining. and then it becomes more difficulty obtaining, and then there's maybe no erection at all, which would be really severe end stage erectile dysfunction. The evaluation for men with ED is actually pretty easy. We don't have to do any real elaborate things. We check blood glucose levels. We make sure the blood pressure is okay. We check oftentimes the PSA. We'll talk about the prostate in terms of its importance in men's health in a few moments. But the workup is actually pretty straightforward, and then we move pretty quickly into treatment. And we have what we have called a process of care, starting with the simple stuff and working our way up to more potentially invasive or complex treatments. So first-line therapy is what we call PDE5 inhibitors. That's Viagra, Cialis, Stendra, Levitra. Those are the brand names of the medications in that class, which really changed the world. These drugs are safe. They're effective in probably upwards of 65% of men who have more advanced vascular issues, say the 2-pack per day smoker with hypertension, diabetes, probably is not going to respond well to oral therapy, but a majority of men will, and it's safe for the most part. I would defer to our cardiology colleagues that it would not be something safe if your heart could not tolerate the exercise of sex, which has been actually studied, and it turns out it's really not too much. The average man in a sexual relation will probably expend as much energy during sexual activity as it would take maybe to climb a flight or two of stairs. So if you can climb a flight or two of stairs without significant chest pain or shortness of breath, then you're a candidate for these medications, especially if you're not taking any nitroglycerin-containing medicine, because those drugs together are not good for each other. If pills don't work, we move up to another treatment called injection therapy. That has been around since the 1980s. We teach the man how to inject a drug directly into the side of the penis with a tiny diabetic-sized needle. I've got thousands of men who have used it. Unfortunately, because it may not be the most attractive approach, a lot of men, even if they're getting a good result, may say, I don't want to do the injections anymore. But it's certainly an option that a lot of my patients enjoy. We have vacuum devices, an external tube that you put on the penis that will draw the blood up into the penis. Somewhat clumsy and unnatural, but certainly can work in a well-established relationship. And then the final option would be placement of a penile prosthesis, an implant. There's nothing new about these things. They've been around for over 50 years. I myself have placed over 4,000 of these devices, and they tend to be the happiest campers I have in my practice because they get what they want when they want it. It's an outpatient procedure. It's very well tolerated. Pain tends to be short-term, if at all. They can fail mechanically. They're designed to last for life, but about 20% of men will experience a mechanical failure in 10 years. So we look at the other way, 80% of men in 10 years still have a functional device. And then there's risk of infection. Anytime you put something foreign in the body, like a knee or a hip or a penile implant, there's a risk. My infection rate going back to 1987, when I started doing these here in Chicago, is 1%. So that's just an overview of one important part of men's health in urology, and that would be ED. The second would be low testosterone. There's a lot of attention to testosterone now. We recognize that it's a very important hormone for men. Basically, every tissue in the body has receptors for testosterone, meaning that if there's a receptor there, it probably has a role. And the testosterone has to land on that receptor to activate the process within the cells of the body. So, for instance, our bone marrow responds to testosterone to make red blood cells. Our bone itself will strengthen as a result of testosterone, or the reverse can happen where not enough testosterone, we can see diminished bone marrow density, diminished muscle. Other symptoms that can happen associated with low testosterone, and that's the hypogonadism that was being mentioned earlier, can be tough to say. Those would include a diminished libido, diminished exercise capacity, easy fatigability, just a loss of joie de vivre and interest in doing things, becoming a real couch potato may indicate that there may be low testosterone. It certainly is more common in men who have chronic medical conditions, and probably the two most prevalent would be in men who have diabetes and obese men. Oftentimes have low testosterone because the fat actually metabolizes the testosterone away. Testosterone tends to peak for men in our mid 30s, and then 1% per year will tend to diminish that level. So depending on where you are in your mid 30s, if you're already starting with somewhat of a diminished T level, you may get into a low testosterone level earlier in life. Unlike in women, where with estrogen, they hit menopause and then boom, the estrogen just drops off a cliff. For men, it tends to be a slow, gradual process. But depending upon when your T is and how long you live, it's possible that you can get low testosterone. And the goal here, in terms of treatment, is to try to normalize the testosterone, get it back into the normal range, not trying to create above normal Superman levels, because that doesn't benefit us and is unnecessary. There are a variety of treatments that are currently available for low testosterone. Injection therapy has been used for many, many years. There are topical gels that can be applied. There's actually a new approved oral tablet, sometimes hard to get and expensive, but oftentimes we can negotiate with insurance companies to get it. So there's a variety of options in terms of treatment. And unlike what a lot of people thought historically was that taking testosterone is dangerous, particularly in terms of your prostate, it could cause prostate cancer. There is no evidence whatsoever that testosterone itself causes prostate cancer. If one had prostate cancer, we might, not always, but we might accelerate the growth of that cancer, but it doesn't cause it. And so if a man has these kinds of symptoms, the best thing to do is get a morning testosterone level before 11 o'clock. Don't have to be fasting. And just to see if we've got symptoms and we have a low T, so to speak, we can initiate evaluation for treatment. The next item is what's called Peyronie's disease. Peyronie's disease is what we call a disorder of wound healing, which basically means that these tissues within the penis scar inappropriately. We get excessive scarring without normal resolution of the scar, and that can result in deformity of the penis, particularly in the erect state. And those deformities can include curvature, narrowing, indentation, and probably the most devastating is shortening of the penis. It affects about 10% of men, so it is not unusual. And Rush in our clinic is probably one of the foremost clinics in the world on Peyronie's. I personally have published over 100 papers in the medical literature on Peyronie's, so we have a lot of experience here. It is clearly both physically and psychologically devastating for the affected male. Unfortunately, we do not have a readily available, reliable, non-surgical treatment to cure the scar tissue. But there are some things we can do that can stop progression and maybe get some regression on a non-surgical basis. But if the curvature remains and the deformity is bothersome, then we have a variety of surgical approaches that can be used, which are safe and effective. The next issue is prostate. Well, men have prostates, and if you're a man and you have testosterone, your prostate's probably going to be growing. And that's just what happens with life. And probably 80% of 80-year-olds and 90% of 90-year-olds will have enlarged prostate. So it tends to correlate with age. Now, having an enlarged prostate doesn't mean you're going to have a problem or symptoms. And having an enlarged prostate doesn't put you at higher risk for prostate cancer. We'll talk about cancer in a moment. It just means that you may be more apt to have what we call LUTS, L-U-T-S, lower urinary tract symptoms. So decreased force of stream, a slower stream, in other words, hesitancy in getting started, intermittency, stop, start, terminal dribbling, feeling like you're not emptying altogether. And then, of course, there's urinary urgency and frequency during the day. And what oftentimes drives men to see me will be nocturia, getting up at night to urinate. Should know that in men, once we've hit our 50s, getting up once or twice per night is normal. But after that point, 3, 4, or more times, can really be disturbing to sleep and probably should be evaluated. There are multiple treatments available. It's actually, again, a fairly easy investigation to evaluate, in the office in terms of, do we have a BPH, benign prostate problem here that could be addressed? We start with pills as far as medical therapy. There are several out there, and if the pills work, we use them until they stop working. But if they're not working well or there are side effects, then there are a multitude now of procedures to open up the channel so we have less resistance to flow and improve those symptoms that I mentioned earlier. The old-fashioned one is, they call it a TURP, transurethral resection of the prostate. A lot of guys refer to that as the Roto-Rooter. It's the gold standard, in fact, but there have been many new approaches that may be less invasive, maybe more effective, and safer. I'm actually one of the only urologists in the city of Chicago who performs what's called aqua ablation. This is using high pressure water to literally blast away some of the prostate tissue. Again, it's an overnight stay procedure in the hospital, kind of like the TURP operation, but it's much more precise and much less likely to cause adverse side effects. And then we'll have the malignant aspects of the prostate cancer. It is still the number 2 most common cancer in adult men. And in spite of all the wonderful treatment that we have, still 20 to 30,000 men in the United States die per year of prostate cancer. So detection is probably going to be the most important thing. And the way to detect it is with a PSA blood test and a digital rectal exam. There's been a lot of controversy about this over the years, but I think it's been now shown to be quite clear that a man, once they hit 45 to 50 years old, probably should have an annual PSA blood test and a digital rectal examination to feel the prostate. And the combination of these two can potentially identify, long before it becomes a threat, suggestion of prostate cancer, and then biopsies can be done to confirm it. And then we have a variety of treatments. Treatments today include active surveillance. You don't have to take it out. You don't have to radiate. We can monitor it if it's a very low-grade type of cancer. But if it's a more aggressive type, surgery and radiation are both available. They have both improved markedly in terms of successful treatment of the cancer as well as reduced side effects. So first things first, PSA and digital rectal exam, probably sometime starting when a man is 45 to 50. If there's a family history of prostate cancer, dad, an uncle, brother with prostate cancer, probably should start when you're 40 for that type of annual surveillance. And then there are other things which can occur within the field of urology for men's health. There's congenital deformities of the penis, so-called Cordy curvatures, or the urethra doesn't end properly in the penis. These are special reconstructive types of surgical techniques that are used. Men may have what we call a buried penis. This can happen most commonly in obese men. The penis becomes shielded by the fatty tissues and sometimes can literally be trapped there. And there are techniques to actually release and expose the penis. We have one of the only two centers in the country that offers what we call aspiration and sclerotherapy for hydrocele. These are fluid-filled sacs within the scrotum that can be cosmetically unattractive or get in the way. They don't cause any problem necessarily medically or from a life span aspect, but can be quality of life compromising. We are able to actually put a little needle in the office. I just did one on a gentleman today who is 79 years old, not able to tolerate surgery. So we just did it here in the office, and he just breezed through it with no discomfort whatsoever. And with that approach, we have a similar success rate to surgery, where we can do it as an open fashion, but it requires general anesthesia in the operating room and so forth. So that's another option. And then finally, there's male infertility. About 50% of couples who experience subfertility, it could be due to the male or in combination with the female. So the male needs to be evaluated as well. Just because a man is ejaculating fluid when they have an orgasm does not mean that there's normal, healthy sperm there, or maybe there's no sperm there. And so this is a process that's, again, fairly easy to evaluate with a semen analysis, some blood tests, and a physical examination. Rush has got a good center here in terms of addressing male subfertility. We also are very happy to have some outstanding what we call reproductive endocrinologists. That's the female side fertility specialists. And as a team, we can have great success with couples who are having difficulty making babies. So that kind of wraps up my summation of andrology as it pertains to urology. Thank you for your attention.
Hannah, can I just jump in real quick and piggyback? Huh? Or Patrick,
yes.
Can I just jump in, Dr. McKnight?
Absolutely, Dr. McKnight. Go ahead.
Yeah, so thank you, Dr. Levine. That was really, really insightful and kind of pulled together some of the things that, we've been talking to with some of my patients. And forgive me, I'm driving, so I'm going to keep my video off and for sound issues. So let me know if there's any trouble hearing me. But, I went to a Mayo Clinic conference a few months ago, and a really fascinating finding in a study that men who experience erectile dysfunction in their 20s or 30s are at much higher risk of heart disease later on in life. Now we think about, it's all about blood flow. The smaller vessels are affected earlier. So if that's not a motivation, right, and I'll joke with my patients that, listen, your body will send blood first to your brain, your heart, your kidneys. Unfortunately, the tackle is last. So I have gentlemen who come in with very uncontrolled diabetes and overweight or obese and saying, Doc, I have trouble with sex drive. I said, well, listen, we can certainly work on that. But the first thing is we have to work on the diabetes, the blood pressure, and the weight. It's not guaranteed, but there are certainly good physiological reasons why those things will help improve sex drive. Okay? That was one thing. And then I just want to clarify, I was discussing Dean Ornish's work, and he did prove that these programs work, and Medicare pays for them for heart disease. Any Medicare participant can go on to deanornish.com, and I'll spell it, DeaNornish, that's .org actually, and see if you qualify for early heart disease, early prostate cancer. He just did a study for mild cognitive impairment. Eventually, that may be an option. It is fully online to take you through these changes and have support. So I just want to leave with that.
Yes, absolutely. So I think, something that's really common amongst all three of you, and want to commend you for that as well, is your approach to not only just treatment, but also prevention in your practice. So what would you say would be the kind of key takeaways for men who are watching this, or people who are maybe have a man in their life who isn't willing to join the lecture but wants to talk to them about this, what would you say would be like a key takeaway for each of you for, one thing to be aware of or to practice in your daily life?
I'll jump in. I think the first most important takeaway from my vantage point for movement and how it relates to prevention is just do it, right? And I think that don't get held up in the stigma of, well, if I'm not doing this, then it doesn't count. And I think really it's making physical activity personal and making it work for you is what matters. And that doesn't have to be, like I said, everything all at once. It can be like a little bit here, a little bit there. And if you get, it doesn't matter how you get to that 150 minutes. If you get there, you get there. And so I would say don't let the metrics of what these recommendations are get in the way of the practicality of living. And I think that is by and large for a lot of medicine, it's, you have all these guidelines that are based off studies, but in reality, doing something to move you toward health is what matters. And it doesn't have to be all at once. And it's likely not going to be all at once. And so taking small steps is what's going to lead to sustained health, as opposed to trying to do, one big bucket of stuff at once. So it's not attainable and it's not sustainable. So that'd be my takeaway.
Well, I couldn't agree more. I think that sums it up nicely. Men have to be motivated. I think men tend to be less attentive to our health than maybe our female counterparts, and we oftentimes rely on our daughters, our wives, our mothers, to drive us. But I think men have to take, command of this themselves and take responsibility. In fact, one thing that I encourage my men in terms of just sort of a checklist of things that they can do to pay attention to their health is what I call Dr. Levine's 4 no's, as in knowing your blood pressure, knowing your cholesterol, knowing your weight, and knowing your PSA. If you pay attention to those no's, it means you're probably paying attention to your health and getting that assessed periodically by your physician. And I think an annual basis is certainly at a minimum what an adult male should be doing. That would be a good idea. And then the final thing I would recommend besides the 4 no's would be establishing in your wallet a list of all your medications. Write them down, write down the dose, write down the name, write down how frequently you take it. God forbid you end up in an emergency room and you're not able to communicate, what are the drugs that you're on, because there may be certain medicines that you might thought that might be needed that might be contraindicated. So write them down on a little card, put it in your wallet. The names of these drugs are so crazy, you couldn't possibly pronounce them, never mind remember them. So just write them down so that you can pull it out and say, here's my card. And boy, oh boy, the doctors and the nurses in the ER will love you for it. And it'll be good for you in terms of general health.
Absolutely. Thank you, Dr. Levine. Dr. McKnight, your takeaway?
Yeah, absolutely agree with Dr. Levine. Really, really good advice. And certainly as far as Dr. Fitzgerald's, like, patients do get, they kind of get stuck with, I got 2 hours in the gym. No, it is when you can do it. Put on some music, have a family dance if you have kids, a jogging stroller if you have kids, something where you can work it in your day and enjoy. Remember the high you have from exercise, right? I joke, we all need our dopamine, right? There's a lot of ways to get enjoyment out of life, and there is a high from exercise. Remember that when it's hard to kind of get off the couch, because that's what motivates, as opposed to the numbers or a doc who's is barking in your ear, right? Remember the high you have from movement and exercise, and use that to just take you to the next little step. And the other thing is, genetics loads the gun and environment pulls the trigger. And what I mean by that is, I would add to Dr. Levine's no's, know your family history. Now I'm going to contradict this in a small way, because yes, you want to know your family history, and yes, there's only so much you can do about your family history. But if you know your family history, you know, okay, I might be more susceptible, so I have to maybe work a little harder or do things a little differently. Because there was a study that showed that, the telomeres are the ends of our chromosomes, right? You think about like a shoelace that has a little wax wrapped around it. They keep our chromosomes from damaging, right, from being damaged, but they do get damaged. So over a period of time, with the right lifestyle changes, we are able to repair our telomeres, right? And that is something that is really fascinating, that we can literally change our family history. And this is just, mind blowing. And so, I just my main takeaway here is just take stock of where you're at, leave judgment at the door, do not beat yourself up, and see what you can do to feel better. Hopefully without excess drugs, alcohol, so forth, right? Moderation and everything. But see what you can do to feel better. And usually that starts with drinking plenty of water, getting good rest, exercising fairly regularly, working on mindfulness, working on the belly breathing. And the other thing I didn't loop back to was positive visualization, right? We know the power of worry. We are thinking of things that have happened in the past, might happen in the future, and what happens. Our mouth gets dry, our chest gets tight, we get a backache. So we can flip the script on that and take it to each part of our life. What am I concerned about? Finances, health, family, whatever. And for a few minutes a day, start to imagine it happening the way you want it to. This is what I talked about with surgery, but this kind of, drills it down a little further. So you can simply take a little break throughout the day. Why? To lower your cortisol and your adrenaline, which is sometimes pumping so high, so often, that we constantly feel like we're being chased by a tiger. Let's reset that with the tools that I've just described.
Fantastic. Thank you, Dr. McKnight. So we have time for our one question, which came through on YouTube. And this comes from a sister who is trying to discuss an incredibly sensitive topic of erectile dysfunction with her brother. And so the question is, how would you encourage a family member to see a doctor or a support group if they need help for their erectile dysfunction?
Well, from my standpoint, I'd like to hear what the other gentlemen think. I think if it's known that this individual, their brother or loved one, is suffering with an issue, tell them that you happen to be aware of a seminar that or a webinar that you happen to participate in like this, and that you learn some things, and it's certainly possible that you can get this problem properly addressed by seeing a physician who has expertise in that area. It's not going to be a shaming process. It's a common problem, and there are lots and lots of options. Without a doubt, the person who's motivated to be able to resume sexual activity always can. It's just a matter of what approach are we going to take to do that. And that may be one of the things that I do, but it could also require some sex therapy and things of that sort, because we know how emotionally charged this problem of ED can be, and that could get in the way of even successful treatment that I might be able to offer. So there's a lot of things we can do is the point, and it's readily available.
And I would just say that the main thing, whatever topic it is, but especially for sensitive topics, I think having someone define their why does it matter to them? Why, as the concerned family member, spouse, whoever, do you want to have that conversation, and why will it matter to them, and help them find that path to why should that matter? And then you can enter into the path of healthcare, whether it's through Dr. McKnight, Dr. Levine, someone like anyone, doesn't matter. But the point is if someone knows what the reason is for seeking treatment, they're much more likely to stick with it and actually pursue it. So I think that defining the why of seeking any care is really a big deal.
Absolutely. One question, a couple other questions came in from YouTube, and I know that we're coming up on time very soon. But you mentioned cortisol. Does stress and cortisol affect or create ED? I feel like we know the answer to this, but please elaborate.
I'll let Dr. Levine give his angle, but I just want to piggyback on that because, if we think about the reality of specifically ED, let's say it happens. Okay, if it happens once, what is the mind going to keep telling us? Oh, this is going to happen. I'm not going to do this. Why can't I do that? Okay, she's going to think this or he's going to think that. What is that going to do? Is that going to help blood flow? It is not. And therefore, cortisol, adrenaline, all related. So it comes to the visualization. It comes to the belly breathing. This is not going to be magic, which we ruled out something organic or something that can be treated. But this is part of the building blocks to hopefully a solution, right? You want your mind to be your best friend, not your worst enemy, right? And certainly it's working with, an individual therapist or a group support, right? There's amazing, ineffable benefits to group support. Breast cancer, prostate cancer, people gathering to discuss something that they have experienced is powerful. The studies are across the board helpful for, and this is certainly an area that, yes, it could be challenging and sensitive, so forth. People have to decide what their preference is, but all of that can be related specifically to ED.
Mhm.
Yep, I would jump on board with that. Cortisol, sort of a negative a hormone, in essence, not one that causes vasodilation and relaxation. Oftentimes, being encouraged by more stressful situations. So, a direct correlation, not something we measure as a test, but certainly something we can recognize. And no matter what the cause of erectile dysfunction is, if it is happening, this affects a man. As I like to joke around with my patients, men care about two things: their brain and their penis. And if the penis isn't working, who cares about anything else? It can take over. And oftentimes it then takes over in a negative way, which interferes with arousal, which is the important thing that triggers this whole process. So I'll leave it at that.
All right. Well, thank you all so incredibly much for your time. I want to check in really quickly if we have anyone on the phone who would like to unmute and ask a question. If so, you can press *6 on your phone and ask your question, and I'll give you a few seconds to do so. And if not, then we will close out. All right. Well, thank you all so much. Thank you, Dr. Fitzgerald, Dr. Levine, and Dr. McKnight, for your time today, for your expertise, and for just sharing this time with our members and with the Rush community. So thank you so much. I do have some announcements for the Rush Generations program. For those who want to continue to stay involved with us, we have a couple of upcoming programs. So first and foremost, we have our Walk with Ease, which is a structured walking group. So we talked about today about wanting to get more active and get that 150 minutes a week of physical activity in. And so this is a guided walking program. Each week, the walking group meets for 30 minutes to an hour to check in and learn information on how they can incorporate healthy habits before embarking on a self-paced walk from 10 to 45 minutes. The next session will be held on Wednesdays, Thursdays, and Fridays at Garfield Park Conservatory starting July 10th and will run 6 weeks through August 16th, and it will meet starting at 2:30 p.m. going to 4:30 p.m. Sorry about that. Next, we have our in-person Take Charge of Your Diabetes workshop that's going to be meeting in the Bowman Center on the Rush campus. And this is a 6-week free workshop for people with type 2 diabetes, pre-diabetes, or those who care for and love someone with type 2 diabetes. Participants will build skills and gain confidence to help them manage their health and encourage them to lead a more active and fulfilling life. This interactive program is a good way to meet new people and share experiences. This class meets once a week for 6 continuous weeks for 2.5 hours, but lots of breaks and lots of activities built in, so don't worry. The next workshop will be held again in person on the Rush campus on Friday, starting July 26th, and go through September 6th and meets from 10 to 12:30 p.m. We also have our Take Charge of Your Health workshop. This is a 6-week workshop for people with ongoing chronic health conditions. Learn how to build skills to gain confidence, better manage your health, and also lead a more active life while managing chronic conditions. Over the course of 6 weeks, we discuss goal setting, nutrition, physical activity, medication and pain management, effective communication with your loved ones and healthcare providers, and strategies for working with healthcare professionals. The next workshop will be held in person on the Rush campus on Tuesdays, starting August 6th and spanning through September 10th, and we'll meet from 1 to 3:30 p.m. We also have our Learning to Live Well with Chronic Pain workshop. This will be a telephonic workshop. This is a 6-week workshop for people living with chronic pain. Participants engage in discussion and skill building activities to better cope with the day-to-day management of chronic pain. Participants will be provided a workbook, a CD, and a book to help guide them through independent learning activities, which will be accompanied by a weekly check-in conference call. The workshop conference call will be held on Wednesdays, starting August 7th through September 11th from 10 to 11 a.m. And of course, we always want to tell you about the Shaman Senior Voices program. Shaman Senior Voices aims to empower older adults to discuss what matters most to them as they age. It's important to share what matters most to you with your physician and loved ones. Shaman Senior Voices wants to hear from you. Please consider sharing your wisdom on why it's important for your healthcare team and loved ones to know your goals and wishes, and also important for them to know what matters most to you. You can learn more at aging.rush.edu/shaman/collaborate and connect, or scan the QR code here on your screen to record on a mobile device or a smartphone. And our next health education lecture will be Spiritual Wellness and Aging, which will meet on Wednesday, July 17th, starting at 1 p.m. Central. Thank you all so much for your time, and take care.